Hey everybody, welcome. It's Wednesday, and we're chilling back here.
You're really
So,
far. I feel like you're far.
I always get told I'm far away.
Yeah, you do.
I may scoot up because I want to sit back, and I know I'll be sitting back. You can tell all your followers that you're started live.
Oh, Gina Bax. We got Gina Bax on. We are going to see Gina Bax.
Yeah, soon. Were you in San
Soon.
Francisco? I saw some post or something like that.
She's everywhere.
God, I'm like,
I need to clean those glasses.
Whatever.
Oh my
Just
goodness.
like getting close, yeah.
Get close, baby.
When we're riding in the car and there's anything on the front windshield, it doesn't really bother me, but it bothers this one. So I clean it for her every time.
Oh God.
They're still dirty.
Yeah. Anyway, so we're here. If anybody wants to split the screen with us and ask us any question related to plastic surgery, Botox fillers, body work, body sculpting, implants, tummy tuck.
You like my body.
If you guys want to split the screen with us, be more than welcome to do that. You just how do you do that now?
Yeah, they have to send requests.
You have to send a request, and we will let you join in. So we're here and open to anybody splitting the screen with us and wanting to ask us any question. But besides that, we wanted to talk about a few different topics. Okay, and so
I'm ready to blabber mouth.
he's ready to blabber about
She told me
everything.
not to talk too much.
So if anybody has any questions, please ask us in the comments or split the screen with us. We're more than happy to do that. And so one of the topics that we wanted to talk about is about fat transfer.
A lot, yeah. I mean, fat transfer to the butt.
So there's a few things. One is I was Googling and reading an article about awake surgery. And there is a plastic surgeon who has kind of poo-pooed awake surgery. And he's saying it is not safe and nobody should have surgery done awake. And it's only done by people who don't have the credentials and aren't board certified. Now, I want you to talk about that. Do you think that's true?
No, there's some elements of the origin of the article, or at least what you just mentioned, some truth in the fact that the awake arena, doing things awake, especially awake liposuction. The liposuction is definitely one of the most popular surgical procedures out there. It's like the top 5, probably number 1. It rivals with breast augmentation. It's probably the number 1 procedure when you look at everything. It can be done in the awake fashion. Obviously, that's what we do all the time.
But are you not board certified? Are people who do it not board certified?
So
you got to answer these questions.
There is a lot of docs that have jumped into the awake arena, OBGYNs, family doctors, whatever, jumping into doing liposuction in their office because they don't need to have hospital, it doesn't need to be done in the hospital. They can do it in their office, and they're trying to get a piece of the pie, so to speak. But they don't know how to do it, and they are doing small areas. They're not doing it correctly. They haven't been trained in it. So, they can be hurting people and having poor results, and they don't know how to numb correctly. So where that comes into the safety issue is that if they don't know how to numb correctly, then they just keep putting more and more numbing medication, and then all of a sudden they're overdosing the patient, and that can put a patient at risk for lidocaine toxicity.
So let's back up. How do you know how much to put in? How do you know what the final amount is?
It's a secret. No. So it's based on weight, right? It's based on weight, and we weigh the patients, and it gives us a number of kind of maximum lidocaine that you can give in a
milligrams
setting.
per kilogram.
Milligrams per kilogram. And so if you're looking it up online, it's different for like straight injections of high dose local into certain areas. This is injection of local anesthesia into the fat, which is definitely different than when you get at the dentist and they're injecting into your face, and it can be absorbed by the vascular system at high amounts. So you have to know where you're putting it, which is in the fat. And when you're putting it in the fat, you can give a higher volume, but there's still a max that you have to respect to stay within the safety realm. So when patients are getting lipo by somebody who's not board certified and doesn't know exactly what they're doing, and they're giving local anesthetic, and they can't get them numb because they haven't laid it down correctly, and they give them more, and they give them more, and they give them more to try to get it done, and then all of a sudden they're in this toxic lidocaine arena, that's where it becomes unsafe. And that is likely what some of the article is alluding to. And also usually when people are writing these articles that, oh, it's unsafe or you shouldn't do it that way, it's because they don't know how to do it that way. They don't have the patience to do it that way, and so they're squashing it because they don't do it like that.
And we have Athena watching right now, and Athena, if you want to split the screen with us and let everybody know your experience, please do so. Just ask to join. You're more than welcome to do that. She says, I love the experience of being awake when I had my lipo, and I had my
leg done with another doctor.
And she was put to sleep, and that was more painful.
Yeah, than I've ever experienced. Yeah, listen, you don't feel anything when you're totally unconscious and you're asleep, right? But it's a higher risk scenario because the anesthesia, and although that can be safe, it does increase the risk.
They don't know.
When they don't know.
But Dr. Yovino does.
When a person wakes up from general anesthesia, if they haven't been numbed very thoroughly, then they're going to feel like a truck hit them, and that's a much more unpleasant experience to just all of a sudden get hit with a bunch of pain as to being slowly kind of sore as numbing medication wears off after the procedure has been done. So, these general anesthesia situations usually are associated with a lack of numbing completely. I'm not saying that's across the board. There's surgeons that do very good work under general, and they know that numbing is really key. And so when I do things under general, I always thoroughly numb an area, very thoroughly, so that way patients are comfortable when they wake up.
Athena says she's shy.
Oh,
he was telling me yesterday.
But thank you for commenting, Athena.
Yeah, thank you, Athena.
It's nice for patients to throw in their experience.
What I thought was really cute is yesterday he was talking about his way of doing things in the OR, and he's like, I'm just so comfortable now. I walk in and I just try to make the patient feel very comfortable, and it's all in the way that I just drape them and I lay things down and I put my drapes on, and he's like doing this like, almost like that salt thread guy does the salt. He's sprinkling it down and doing this, and
Yeah, I think about when you go get a massage, or somebody that's like really a good masseuse, and they have very slow movements. They're not bumping into the bed. They're not like hitting you. They're laying things down real slow. They're touching you in a soft manner. Mm-hmm. And that creates a very calm environment. And I think it's really key.
Not slamming the cabinets.
Right. Yeah. Yeah. You want to maintain a real peaceful environment. You try not to break that scene with something like bump or twitch or a slam of the door, any of those things. So it's really important part of the whole scene, right? Obviously you have to numb the patient.
You're not throwing instruments or anything.
Not stomping. Yeah, no. And I really, when I'm doing the procedure or when we're doing it, really part of the whole precision sculpt experience is keeping pain to as minimal as possible, and even trying to eliminate like things that are typically painful. Patients that have been through the experience know that when I numb, we're using a needle and we're injecting numbing solution in the skin before the incisions make it, and I grab the skin and I shake it right as I'm entering in, and a lot of times patients don't even feel it, and they make the comment of like, "Are you in?" And that's because that's what the joke is. Yeah. Jesus, look who's inappropriate today. I'm gonna get my 2 fingers out. So you can make all throughout the procedure. I do specific things to keep it as low pain and not really even pain. It's just like minor discomfort here and there.
You're like all the way back here. Like, look how little I look if I do that.
No, you look smaller. I like you looking, more huge. Not huge.
So we are available here to answer any specific questions people may have about Botox fillers, let me kind of get closer to you. Botox fillers, or any kind of surgical procedure.
So you know what? I had a patient the other day that it's it's related to
What happened to my rubber band?
Related to fillers. So she works for a company that does fillers. She does fillers, and I said, "So what filler are you using?" And she said, "Oh, it's only Juvederm products, because they have a deal with them. They have an agreement or whatever. So they're only locked into Juvederm."
And this person works for Allergan?
No, they work for a company and she does injectables, and she can only use Juvederm products.
Excuse me, Gina. I never have to take a back seat. What are you talking about? I need to school you on how to do things.
No, you don't. You don't.
Okay, go ahead. So you're talking.
So anyway, she can only use Juvederm products, and I was like, well, that's a handicap, right? Because
she works for a company. She injects, and she can only use Juvederm
right.
products. Okay,
their agreement is with they only get Juvederm products, so she's limited by that because why? I mean, if you could only
I don't want
use
to throw
Juvederm,
any company under the bus.
No, it's not throwing them. It's just like having a variety.
Look, in the past, in the past, there really was only one major filler brand, and that brand was Juvederm. They were kind of the gold standard. Anytime someone got fillers, they always said, I want Juvederm, I want Juvederm. And so for years and years, people used them. And then other companies got FDA approval for dermal fillers in the United States, and slowly practitioners started using those fillers. And what we realized is, these other fillers have multiple different kinds of fillers of multiple different densities and stiffness and softness and
hydrophilic or hydrophobic, water absorption, water not absorption.
Right. So certain products are like, oh wow, these fillers, you don't swell as much as you do with Juvederm. The filler doesn't migrate as much as it does with Juvederm. What you see is kind of what you get after you inject it. So I think a lot of people started dabbling in other fillers, and that's what we've done. We've kind of branched out, and we've started using other fillers and other brands, and we have, like 4 or 5 different brands in the office now. And so, that's kind of what we're doing.
And, you picked them. How do you choose which fillers you pick?
I choose depending on what the patient, where I'm injecting. So if a patient wants, for instance, their lips done, I always ask I say, well, how big do you want them? Do you want them juicy or do you want them natural? And so depending on what they want, I will choose a filler that I can achieve as close to those results as possible. Some people, if they have really tiny and thin lips, I might need to inject them more than once. 1 cc won't be enough. But there are some fillers that are a little more bulky, so even at 1 cc, they can have a good fill. And then also there's longevity in fillers. Some fillers on the market last now 15 months. So it depends. I mean, I want one that moves nice and softly around the eye or around the mouth. I don't want a very stiff filler. I want one that's stiff that goes in the jawline or chin or cheekbones.
What do you like for the jawline?
I'll tell you all the stuff that I've used. I use Voluma.
Drum roll.
I know. So I've used Voluma, Wrestling Lift, Radius. Radius is not a reversible one, but I've used Radius. And then I have also, now Define. Restylane Define is now FDA approved for the chin. So we've been starting to use that for chin augmentations as well. So it kind of, really...
It gets tailored is what you're saying. It's tailored to the area, to the desires, to the anatomy, to
sometimes how they've responded to previous filler. Like if I've used Wrestling Lift on somebody and they come back complaining, oh, I don't feel like it's lasted, I may switch to a different filler that I think they might not break down as quickly. So I just kind of, it all depends. I sort of shift around. But they're all really great. You know, I do inject.
You're being nice.
I did. I do inject less and less with Radius because Radius is not reversible. So if I feel like the patient is unsure of what they really want and how much they want injected, and I feel like they might be a candidate that might not like the results and want them reversed, I won't choose Radius because Radius cannot be reversed. So, you know, that's another
Tell
thing.
us about the reversal. So it's really powerful, right? To have a filler be able to be reversed if you don't like it, right? The whole idea is that you like it. But if you're like, this is just not for me, it's not what I expected, I feel uncomfortable with it, it can be easily reversed. How does that happen?
So, you know, there's agents that will dissolve the hyaluronic acid, and hyaluronic acid is the component, that's what the dermal fillers are made of. So it's just a simple injection. Injection gets injected wherever. Say somebody, you know, most people are more commonly think about the lips when reversing, but some people say they get their cheek filler and one side looks a little off. Then there's two options. You either put more in the opposite side to balance it out, or you reverse the side that seems more full or a little off. So there's, you know, you just inject it, it dissolves it almost instantaneously. And then we usually wait about a week to re-inject. So one common place to get filler dissolved is right here on the white portion where his mustache is. It is the white portion of the lip. So previous injections in the pink part have migrated up here. And so this portion of some people's mouth is really, really full. And if you look at it from the side, it seems to project out a decent amount, and they don't like it. And this part of the, you know, their pink part starts to roll downward because they have so much filling here. You would see that in hydrophilic fillers like Juvederm Ultra or Juvederm Ultra Plus. So in the past, when people would have those two fillers injected, even if they were injected 5 years ago with the product, you will see fullness that remains here despite the fact that they're no longer being injected there. And so that's a very common place for me to reverse.
Yeah, or it's just not migrated, it was just injected there, right?
Yeah, so sometimes people would inject these columns, maybe they put too much in, or maybe it was the person's technique, but I think a lot of times it is migration.
Yeah, it's so strange how it migrates through tissue if there's not really a surgical space created, right? You know, like,
well, you know,
why
now
would move.
So there's a new trend of injecting, not new, but you know, injecting kind of this way around the lip, and I've done it. I mean, I know a lot of people inject it that way. It does help roll the lip outward.
I did it on you.
You did it on me, and it does help roll the lip outward. So people love it because you don't need quite as much filler to show that you've got volume in the lip. So it is a nice technique. But if the needle insertion is above the vermilion border, and then as you inject out, the filler gets injected the entire channel at the very end, it's going to be above the vermilion border. And then, hi Tammy, welcome. But it will be above the vermilion border. So Tammy, we're just talking about Botox and fillers and surgical stuff. Anybody that has questions, we're saying, you know, ask us questions. We are here to answer anybody's question. Or if anybody wants to split the screen with us and join us live, feel free to do that. We will be more than happy to answer any questions in front of our audience.
So maybe let's switch to
what?
Different topic or no?
Yeah, whatever you want.
The BBL topic, right? It's
and BBL stands for
Brazilian butt lift.
Brazilian butt lift.
BBL.
BBL.
So
how did they who invented BBL? Where does that come from?
The Brazilians.
Okay. And who specifically? Is it Hoyos Brazilian?
Yeah. Oh, I don't know. I think he's Colombian. No, but I think it came out of Brazil and a transfer of fat into the butt, and so when it was actually coined or that, I'm not sure about that. But BBL is stuck. You know, Brazilian butt lift is now converted to BBL. It's easier to say that. But the reality is it's a fat transfer to the buttocks.
Now, would butt implants be called BBL too?
That's a good point, but typically no.
Okay.
No. At least not that I'm familiar with. BBL is always associated with fat transfer. But I guess it depends on who you're talking to. And where
now, what if someone came to you and they're skinny, and they're like, I want a big butt?
I tell them they can't have that unless they do buttock implants. Or Sculptra, but you still don't, if they're looking for big butt, it's really challenging to get that with Sculptra because you need a lot of injections. And it becomes very
hundreds of thousands.
Prohibitive. And so,
unless you have your own.
We have Tyler.
Sorry, you guys moved my M&Ms.
Hey, do you want to come here and tell people how you feel after your COVID shot?
Well, the first day.
Well, no, come over here. Sit here. Say hi to everybody. Come on.
There's only a few people on here.
Yeah, there's only a few.
And they're friends.
Come on, just say hi.
Gina's on there too.
Come here.
No, you don't need to.
It makes it a lot. So tell us about your COVID shot.
We can't hear from you over there. I can't hear it. La 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 la. No, come here.
Go ahead.
Sit right here.
Tell us about her.
So the first day it didn't really feel that bad, but the second day when I woke up, it hurt to move, and anything that would touch it, especially my backpack strap, would just make it sting.
Okay. Did you have any side effects from your shot?
I felt sick this morning.
Like what? What do you mean you felt sick? I drove you to school. You didn't even complain once.
I drove you to school.
Oh, yeah, that's right.
Taking all of
God, what the hell?
Yeah,
of course I'm taking all the credit.
If I was in here.
Jeez, king up on me.
Of course I didn't complain because Dad was there.
Did he complain to you?
Hey, about his arm? Yeah.
Okay.
But I told him toughen up.
No.
Get tough. Right?
Look at me.
Bye.
Where's the M&M?
So, he had his COVID shot, and he's,
First one of two.
can't tolerate discomfort very well. Not like, old school. We were talking about BBL, fat transfer, buttock implants. If they come and they're super skinny and they're like, I want a big butt, then that's a challenge because the best thing is using your own fat. If there's not any fat to transfer, in a very small amount, then you can't have a significant result. And so sometimes I'll turn down patients who just don't have enough fat and to achieve their desired goal.
What about those fat stimulating stuff? Those like injectables that are fat from cadaver or something. What was that? What's that?
Yeah, I forget the name of it because I'm just not excited about it. I don't remember.
But you need probably a lot of that as well.
You need a lot of that stuff if you're not using your own fat, if you don't have a large volume of fat, or not using buttock implants. Not that I'm pushing for buttock implants. It's just that sometimes that's required to achieve an outcome of significance. So we don't do buttock implants, but we do plenty of awake butt lifts. It's our signature fat transfer to the buttock. But you do have to have fat to transfer.
So I have a question.
It doesn't have to be a lot, though.
So what is the minimum amount of cc's that you would put in each butt to be worth it for somebody?
So minimum is usually about 200 cc's on each side because the survival is about 50%. So that means you're going to get about 100 that stays. Anything that is really less than that is very,
and
very
how much
subtle.
is 200? Like, what is that?
I mean, it's, well, if you look at it like a little pancake, right? A little disc, it's going to be like this. So kind of spread out. So in those situations where we only have like 200 cc's, we focus on a certain area of the butt and not the whole thing. It could be a portion of the hip dip or where it's dipped in the most. We're going to get that. It may not completely fix the dip, but it'll make it better. So you have to be very judicious about how you're going to use it, because you don't want to just spread it all around and then patients are like, oh, I don't notice anything. You want to focus on a zone that needs the most attention, it needs the most help, and that's where you give it.
And where are you getting the fat from? Are you getting it from like someone's like
your mama?
My mama?
So most common areas are the abdomen, the waist, the flanks, the love handles, the mid and lower back. Other areas can be the arms and the thighs. Those are kind of the main sources. Most of the time it's coming from that 360 abdomen because that's usually the juiciest spot, and that sits essentially right adjacent to the butt. So the more that gets brought in, the better the butt looks just by itself. And then if you're able to take that and add to the buttock, so this move plus this move is even more powerful than just one direction.
One direction. So if somebody was having body sculpting done and they were wanted to use their fat and move their fat, and they're like, I kind of want a whole body reshaping. I want my boobs done and my butt. Would you do them both? Could they get them both and just lay on their side and get them both like?
I don't prefer it, and I really don't do it that way.
And why not?
Because you gotta stay off the area that gets the fat put into it. Because fat is fragile, putting pressure on it can decrease the survival, you get more absorption of the fat cells, and you get less of a result. So you want to keep pressure off of it, you don't want to be putting all your body weight on it. So if it's a fat transfer to the buttock area, the hip dips, you stay on your stomach, you stand, you sit with a specialized pillow behind your thighs, so you baby that area. How long? 2 to 4 weeks. I really push patients into 4 weeks because I think it just looks a little bit better. Same thing for the breasts. You got to sleep on your back, right? So if you're doing breast and butt at the same time, you got really no place to lay. And if you lay on your sides, you're going to be laying on the fat that's been put in the hip dips.
So Tammy is saying she thought her hip dips are called curves. So where exactly are the hip dips?
So, well, I mean, anything's called a curve, so I'm not sure what.
But what's the hip dip? Is this the hip dip right here, or no? The hip dip's down here.
Yeah, so hip dip's not really a technical or medical term.
Oh, I found in my book. No, I'm kidding.
Everybody has some sort of dip in the lateral
Jasmine.
buttock, that junction between the outer thigh and the buttock area. So you're kind of coming up on that outer thigh, and then as it comes into the buttock, there's always a little dip in. Some people have more, some people have less. There's really not a lot of natural fat in that area. So pretty much everybody has hip dips. It's kind of it's almost a masculine look, because all guys kind of definitely have it. A little less with women, and that probably
An
has to do with
athletic
the
female
pelvis.
body wouldn't have hip dip. I mean, would have hip dips.
Yeah,
It's
but-
not really masculine.
Okay, however you want to look at it.
Oh,
jeez. So that dip is essentially this area right here, right? Which is really like if you're looking at the butt, right? And then it's...
What is this?
Get out of here.
What is that?
Some bullshit right there. Bullshit. So it's the outer part of the buttock, really. It's the lateral or the outer part of the buttock that typically goes in a little bit. That's a little concavity, and that looks much better when it's filled, because then it typically matches the waist, and so it really helps enhance the curves.
So we have a question. I have a lot of inner thighs. How would you remove it? Because I get very bad scars.
That's the problem with inner thighs, is that the precision sculpt of the inner thighs is great, but it's for specific patients.
Now,
Any sort of
who's
like
that patient?
That's patients with good, healthy, tight skin there with kind of isolated bulges. Not any sort of laxity in that area or irregularities naturally, because those can get worse. No matter how even it's taken, you get some deflation of the tissue there. And so, how do you manage the excess skin? Well, you have to remove it, and that comes with scars. And there's no way around it. You typically need a scar that runs down the inner part of the thigh to
Ew.
give the most powerful change, because that is the movement this way, and this inner thigh, you need to take it out this way, and with that comes a scar in this direction.
Well, what about cutting along the groin and lifting up like a sock?
The problem, yeah.
What?
Or maybe like what do you call the tights or something like that?
Yeah,
or
like
uh,
the socks that Tyler has that go above his knee.
Oh God, I gotta do that. Those scars that are in the inner groin, you can only remove a small amount of tissue, and so you don't get much of a change. You get a little bit of change.
Why can you only remove a small amount of tissue?
Because if you pull it up, it has also a pull downwards. It's going to try to retract down, and it can open the vagina a little bit because there's a pull, and so it does, and it then makes the scar wide in the groin. So they're unfortunately.
What does that mean? The vagina's like down their leg?
You put it in their pocket. Yeah. So, I don't have a real great answer for you on that. I mean, the answer is the answer, but the problem is that it comes with scars, and you have to be open to scars. And when you get the scar, you can't go back. right?
So we have somebody that's saying, is Precision Sculpt right for someone who has flaccid skin?
No, so there's no, it all depends on the level of it, but skin laxity, if it's really hanging off of you, the only way to truly take care of it,
to give you the best result,
is to remove it and stitch it closed. I always look at it like a suit. The suit's not fitting anymore. You know, there's nothing that takes, you can't throw yourself in the dryer and shrink you down. You know, it doesn't work like that. You have to essentially tailor the suit, which requires removal of excess tissue and stitching it. So that's why, you know, and especially for the abdomen where there's laxity and skin is hanging off or hanging down, you really have to entertain tummy tuck. Now, we do offer things like Renuvion or J-Plasma. It's radio frequency. It goes underneath the skin. And it's done in conjunction with fat removal, and it can help tighten slightly. It's not a miracle. I don't care what anybody says. We use it all the time, and it is the best thing out there to boost the results slightly. But usually, kind of if you're on a scale of 0 to 10, it's usually bumping it up by like a half a point or maybe a full point, somewhere in there.
So we have a question. What are your thoughts on the procedures? Hold on, I just moved. What are your thoughts on the procedures where I've seen patients stay awake during breast augmentation?
Well, it depends what you mean by breast augmentation, meaning implant placement when the patient's awake. If that is what you're referring to, typically that is placed, the implant is placed over the muscle. That can be done very easily because that space is easily numbed.
Was doing it in Miami.
And you don't have to, you're not elevating the muscle, so there's no muscle work. And that muscle is what typically is the most uncomfortable in an awake setting. You just can't numb the muscle completely and try to release it. And it also creates a lot of twitching, and it creates a very difficult surgical environment. So,
well, I mean, I'd like to challenge you on that. If you did a paravertebral block in the back, which would numb the entire chest wall.
Do that again.
In the back. And it would numb the entire chest wall. You could essentially do a breast augmentation awake completely under the muscle.
You could. Now, what if it didn't? What if it started wearing off, or if they felt certain parts of it during the middle of the procedure?
You know, some people do them in 30 minutes, you know.
Yeah, but you know, the problem is that it's difficult because you're committed and you're trying to create a space, and if you're limiting how much you can dissect because patients are a little uncomfortable, you're going to limit the pocket and the placement of the implant, and then you're screwed, right? You need to get it right the first time. So, yes, breast augmentations can be done awake, but they're usually done above the muscle, and that is not the gold standard. The above the muscle implants typically don't hold as long. They can form more scar tissue around it, so they're really typically inferior to the submuscular placement.
So the person who had asked you about a thigh lift,
right?
okay, she says she's a lot of, and then it says, is there any kinds of injections you could put so it would not scar?
No. I mean, you know, really not. You know, there's no erasers. There's no scar erasers, especially in those areas. Now, is there treatments to help minimize the scarring? Yes. I mean, there is silicone treatments. There's, you know, silicone creams like Silogen, which we offer in the office.
Steroid injections.
Steroid injections can
soften a scar.
Can decrease the size of a thick scar, but they don't make a scar go away. They won't make it more narrow or erase it. They will just kind of decrease some of the bulkiness of a thick scar. Mm-hmm. Laser treatments and radio frequency can sometimes help blend it in a little bit, but you know, these scars in the thighs are usually a lot more prominent than other areas, and so you know, I say no because that's really the answer to it. You know, you have to know that if you're going to get a thigh lift, you're going to have a scar there, and it's going to be there forever. And you have to.
But there are ways to mute a scar out by lasers or microneedling. If the scar is light compared to the surrounding tissue, you could have like tattooing in there, medical grade tattooing, where they actually tattoo your pigment back into a scar to blend it with the surrounding tissue better.
Yes.
There are ways to blend the scar, but would it look like perfect? No, probably
Yeah,
not.
and it's a big commitment. I'm not squashing it, but you got to be like on board with a lot of treatments afterwards and different approaches, and the cost component of it. So.
So anybody that is watching, if you want to split the screen with us and ask us any questions, we are here to answer them. We are going through our comments and answering as we go along. But if you want to split the screen, we are here to do any just like fly by the night consult.
Yeah, and so you said probably not recommended, I would surmise. Yeah, I mean, I don't recommend a subglandular breast augmentation with an implant. That's
People are typically not happy.
Yeah, I mean, the only time that it's kind of recommended is like bodybuilders, like really extreme bodybuilders that don't want to affect the muscle and don't want to have a lot of animation type deformity because their muscles are. Then yeah, they go above the muscle, but they just have to understand that they can get capsular contracture at a higher rate, which is thick scar around it, which can make the breast a little firm, and it's higher incidence with that when the implant's placed above the muscle.
And then also, so when you're talking about the animation, can you explain what that is? That is when you put the implant under the muscle, and then when the person flexes, the implant kind of squeezes out of the pocket, correct?
It squeezes out. I can't even look that. Like all of a sudden I see the implant coming out. Yeah, so animation, deformity is kind of how we talk in the plastic surgery world. Means that the implants are placed underneath the muscle, and when you flex your muscle, you flex your chest. Your muscle moves, and sometimes the implant moves a lot with that muscle contraction. Sometimes it doesn't. The majority of the time, it's not anything other than just normal chest movement, but sometimes it can be exaggerated. That is a risk with the submuscular placement that can occur to a level that you don't like, right? How to diminish that? Well, there's a lot of techniques about muscle releasing in certain areas, and that's key to decreasing some of those contractile elements. There is, if we had Daniel Core on here, and I don't know if they're still doing it, but I know they were doing a subfacial breast augmentation, which essentially is placing the implant above the muscle but under the fascia of the muscle. So they're getting the coverage of the fascia, so they're getting some extra coverage but not messing with the muscle. So therefore,
attachments.
Therefore they potentially get less animation type changes. I'm not sure the longevity of that or the capsular contracture rate. It's a very kind of infrequent way of doing the procedure.
So let's talk about some things that are maybe unusual. What is, if you can think back to the last 10 years, what is the strangest thing that you can remember somebody asking you?
The elf ears?
Huh? Elf ears?
Elf
ears. I
ears.
don't know. Yeah, what's that all about?
Were you thinking something else?
No, I'm asking you.
Yeah, well, I remember somebody called into the office asking if we make elf ears. And I
forgot about that.
Yeah, it was a joke, right? I was like, huh? Yeah, I remember this was back in Fort Lauderdale.
So when he first started his practice, he had started in Fort Lauderdale, Florida, and was in practice for 3.5 years.
Right.
You were doing a lot of ER plus regular private practice.
Yeah,
so you saw some weird things.
Yeah, doing kind of everything that walked through the door that I felt comfortable with. But yeah, somebody called up asking for elf ears, and I was like, hey, no, I'm not doing that. But then later on, I think I've seen it on TV, like people doing body changes to make themselves into characters, right? And essentially you could cut into the cartilage and stitch it and make, points, and you can do those things. But, that's the first thing that kind of came to my mind from a cosmetic standpoint. I've had...
What about the woman with the breast? I know I just mentioned this recently, but the breast issue, and she said something... She had an infection in her breast or something, and it was like a paper or a pin or something.
That story comes from my aunt, I believe. Like Catherine posted something about.
No, you said it was your patient. I remember.
I don't know. I didn't buy any of that shit. They were saying that they found like a note in their breast and they never had any breast surgery or something like that. So there were, it's that ancient alien stuff. So I don't know that. You like that story because
I think it's weird. I don't know.
Super weird. It doesn't make any sense, so I'm not giving it much brain.
So so we're talking about the strangest things he's ever been asked to do for plastic surgery. So let's go thing by thing. The face. Besides the ears, was there anything strange with the nose, the lips, the face?
Well, I try to keep the strangeness out, right? I try to. We have a nice, real, genuine, realistic practice, and I've been fortunate to have a lot of great patients that come through, and so we don't get a lot of off-the-wall stuff. They tend to weed themselves out.
No, we do get some.
I don't. There's so much anymore. I remember, some years back, a woman had come in, and she was like pulled so tight. Multiple facelifts, like came in and she was talking about how loose she was. And then she needs to be pulled tighter, and I was just like, it was like, what? I think she had a brow lift, so she looked like she was like this, like so surprised, and she was like, my brows are dropping, and so I'm like, no, I'm not the right guy for you, but I got this guy over here, and so I think I sent him to somebody that
that hates you now.
That hates me. But yeah, there's no reason. That's crazy, right? She already looks like she's in a wind tunnel and permanently, and she wants more. So clearly, I'm not going to be able to help it. If I was to try to help, it becomes my problem, and that's not the proper approach. You do try to do the right thing. You make smart decisions based on patients' anatomies and the realistic, or unrealistic goals of a patient, not based on money.
Okay, now what about breasts? What's the weirdest thing with breasts that you can remember? Anything? Well, I remember there was one patient that wanted to be the biggest implant that we could possibly get. Remember? And then her boyfriend was in the window, in the thing, saying whether or not it's big enough.
Yeah, right? What was that?
Yeah, that was one of the implants, and then she was going to be under, so he had to give the okay.
Yeah.
Whether or not.
I stopped doing any of that shit now. It gets too complicated. You start getting people involved that don't know what the heck they're doing, and it's emotional and all this stuff. So I have moved away, and I never really was in the arena of doing exaggerated work, right? I think it's a problem. The view of themselves is distorted, so I have really tried to stick with natural outcomes, although enhanced and look good, and but don't look abnormal, because that abnormal arena is riddled with problems. It violates the anatomy and puts too much stress on it, and then there's unpredictability on healing, and then how patients respond. So you try to keep it in the natural but enhanced arena, and everybody's happy.
So we are here to answer any questions. If anyone has any specific plastic surgery related questions or wants to split the screen with us, we are here to answer them, whether it is on non-surgical stuff like Botox fillers, skin resurfacing,
or golf,
or they've got discoloration of their skin or this or that. We're here to answer those questions. And then, he's here to answer any surgical questions that you may have, whether it is in the awake surgery arena, whether it is body sculpting, breast augmentation, fat transfer, tummy tucks. Those are the most common surgical procedures.
Let's talk about back to the fat transfer to the butt. I saw something recently with a surgeon that is, I believe, a plastic surgeon, holistic plastic surgeon. I'm not sure
what
exactly.
Does that mean?
I don't know, but
that means they're not really plastic surgeons.
That means they're not operating anymore or something. But he was squashing fat transfer to the butt because it's the most dangerous surgery in plastic surgery, and you shouldn't do it because you can die and all this stuff. And what they don't tell you is that, first off, he's not doing the procedure at all, probably has no experience in it.
But let's talk about all plastic surgery in general. Is it, out of all the plastic surgery procedures, the one with the highest risk? Yes or no? It is. It probably is.
Maybe.
Okay.
I don't. You have to look at the numbers correctly. There's a lot of it being done, and it's like saying.
Well, it is the most.
I don't know. It's like saying, I don't know, Formula One, right? If you got a good driver and you got a bad driver, right? A bad driver's way more risk crashing than a good driver is. And so
right, but if you talk about Formula One versus Indy versus NASCAR, where's the biggest risk to the driver? It might be Formula One because they go the fastest.
I don't know, but they're more protected. Maybe their
no, they're not.
Like
in NASCAR, you're in a whole car with
the thing is that it's all about who's doing it and how it's done. Right? If we keep the patients in the awake arena, you can't get deep in the muscle. Patients won't allow that. They can't tolerate that. So that is a checkpoint. It allows for a big safety measure to be in place.
Because what's the main danger with fat transfer of the butt? What is the main danger?
Is injecting it deep and getting it into the deep veins that then pick up the fat and travel it back all the way to the heart and into the lungs, and you can get blood clots. You can get fat clots, fat embolism, and that can be catastrophic. So obviously,
fat embolism can go to the lungs and block the blood flow to the lungs.
Yeah, so obviously we don't want that, and so we stay superficial to the muscle. And how do you do that? Well, you know the anatomy. You put it in very slow and meticulously. You never take your eyes off the patient. You have in proper positioning. You have them awake, so that way if you get anywhere near it, they go, whoa, what is that? And you're like approaching danger zone, so you back off of it. But nobody talks about that because it takes a lot of patience, and most doctors don't do it in the awake setting. They do it asleep, and they're just slamming it in, not paying attention, and they're now roped into this arena of unsafe settings where other doctors who are really sloppy are getting into trouble. And so they kind of collectively say, oh, it's fat transfer to the butt. Well, they don't talk about how it's done.
Do you think cannula size
size matters?
Yeah, do you think size matters? Do you think the larger the cannula, the higher the incident, or the lower the incident because then they're not able to get in a vessel because they're bigger? Or what's your thought on that?
Well, the
strained fat versus non-strained fat, does it make a difference?
The societies have put out some suggested guidelines, and one is to not use small cannulas in the transfer setting because those are higher risk for puncturing into these deeper environments and therefore getting into vessels. And if they're bigger cannulas, then they can't. It's hard to get as deep, and they're just going to slide around. So
And that is the same philosophy for injecting with larger cannulas in the face versus a 27 gauge or something much smaller. They're saying if you go to 25 gauge or anything a little bit larger, then even filler. Because fillers in the face can be a problem. You can get it in a vessel too. And so you can have embolism of a filler into the arterial system, which can then go and either block and necrose the face, or it can blind you, which is, and some people would say that's worse, So, yeah, same thing. Go ahead.
Yeah, so maybe there's some truth to it, but if you're in the wrong place, then you're in the wrong place. But if you're in the right place, then that's not an issue. You can use all different sizes of cannulas, and I prefer the smaller ones, not too small, but the smaller ones in general, less traumatic if you're in the right place. And so I'm not worried about trying to use big cannulas. I think in general for the liposuction and the fat transfer, docs use big cannulas because it goes faster. It's easier to put it through, and you can move the case in through much faster, and it's all about speed. In the liposuction arena, because most docs don't like to do it, and they want to get through the procedure quickly, and they're doing it under general, so they can't sit there for 4, 5, 6 hours because now they're running into a lot of anesthesia time. The cost goes way up, the risk is way up. In the awake arena, I can take as much time as I want to get it done very nicely. And so I like to use the smaller cannulas. They're less traumatic.
Your voice just changed. You're like, and I do it.
I feel like I'm back in the OR.
It's
different. It's calming.
You're like, I do
it's calming.
They do like this. And I do it like that.
You notice when you're acting up, I start talking like this.
You're like, yeah.
All right, well...
but do you think using the larger cannulas for the suctioning of the fat causes somebody to have more bruising?
Yeah, I think for sure it's beating up the tissue more. The more you beat up the tissue, the more it's going to be bruised. It's kind of like common sense. If you're gentle with it and you're like carefully picking the fruit off the tree and taking your time without ripping off and damaging branches and stuff, then you're going to have a less traumatized tree.
I'm like, what?
No, but like you think of the fruit as the fat, and if you go in and take it, you can go in and start ripping with big things, or claws to it, or you can take it off very meticulously, and it's happier. Mm-hmm. You don't beat it up as much.
What about fat transfer to the bottom of the feet? Anybody requesting that? And have you done it? Well, some people lose their fat pad on the bottom of their feet.
Yes.
So, is it reported to do fat transfer to the bottom of the feet? And if it is, have you done it?
I have not done that. It has been reported, and
so you don't know. Okay, forget it. I'm gonna ask another next.
No, listen. You can put fat anywhere, man. You can put it anywhere. And
do people request for fat, like for vaginal rejuvenation, like down there, if they feel like they're what?
I don't look at anybody else's vagina.
Good answer.
No, I don't do vaginal rejuvenation.
People.
But yeah, fat can be transferred anywhere. There needs to be some more cushion. And it
cushion for the
cushion. I know, right? Whatever. Yes, so it can be done and has been described for plantar fasciitis, and I think wearing high heels, right? And you get one out, and the feet are hurting. Fat transfer to the area for sure is an option.
Now, what about, they say that one of the main sources for stem cell injections is, of course, amniotic or umbilical cord blood, but some people are removing the fat, and taking the stem cells out of it. What's your opinion on that? And,
I don't know.
What about using the fat as to inject it? Is it stem cells just hanging out there?
That's what they say. I'm not sure how powerful that is. It kind of was a rage for a little while, talking about separating the stem cells and boosting it. And it hasn't really amounted to anything. It's still just kind of lingering out there without any big success that I'm aware of. So I think it was a lot of hope, and their stem cells, sure, but does it significantly change things? It doesn't appear that way. You need tissue. You need real living specialized tissue, like fat cells, not necessarily the cell that's going to turn into something else. I don't think there's any guarantee that happens on a grand scale.
Okay.
So we're winding down here. It's been It's been fun, right?
Well, hello everybody. If you just joined and you have any last minute questions, we are only going to be on for a few more minutes. Feel free to ask us any question that you may have on anything surgical, non-surgical, plastics. Oh, I see someone. You waved. Oh no, I waved at everybody. So if you have any questions, let's talk about fat transfer to the lips. I know we've done that in plenty of patients. What are your thoughts about that? So once someone has fat transfer to the lips, do they never have to use filler again? What ends up happening?
No, they have a better baseline with their lips, and they typically are still going to want some filler down the line to do fine detailed work. I think fillers still reign in the lips because of the detail capability with it. Fat is, albeit small, but it's thicker than the fillers, and you just can't place it real superficial, and it's unpredictable, right? And especially in the lips, you get, you put it in, and the lips are really big, and then they come down, and the end result's subtle. So there's a lot of fluctuations with it. It's almost a long run for a short slide. Yeah, and
long run for a short.
Yeah, long run. Put in all this effort, and then you get a little bit of slide out of it. I find that the fillers...
Is that the saying? I don't know if you're right.
Yeah, long run for a short slide.
Is it? Yeah. For a short slide, or is it for a short ride?
I got it. I'm right.
I don't know. I'm going to have to look that one up.
Yeah. You're not going to look that up.
I'm going to look that one up.
Look that up never.
I'm going to look that one up.
Yeah. Fat transfer to the lips is a good option to kind of start, and it's not unusual to want a little bit more. and do some fillers on top of that. But
so we're talking about fat transfer to the lips, whether or not people don't ever have to use filler again in the lips, or what exactly the results are. So you're saying that the results for fat transfer to the lips, basically it fills the pink part of the lips, but for fine detail work, like say you wanted your Cupid's bow or your vermilion border to be a little more crisp, then you still would need some filler in that area, because it's really more for the pink to make it more, have more volume.
Yes.
Yeah.
Yes.
So fat transfer to the face is great, especially like temple area, nose. Some people get it right here between the eyes if they're really deep.
I think, for fat transfer, I find that the peri-orbita around here and the cheeks tend to be the best. That's where I've just seen the most Success, yeah.
So what if someone gets it done and then they gain a lot of weight? Is their face going to blow up like this because then they're going to get fat in the face?
Yes, they can gain weight in that fat that's been transferred. Usually it's not excessive because it's not a massive amount, but yeah, their face can get fuller, just like a butt can get fuller with weight gain after transfer, or breasts get fuller after weight gain after a transfer. What if I want to remove my implants and put fat? Would they look
big?
No. You're talking for what?
Well, it depends on the size of the breast implant.
They will look smaller usually than how they look with your breast implants. It's not a like for like, right? You're removing the breast implant which is foreign body that has a lot of integrity to it, and replacing it with fat that is softer and not as much volume. So you will go down in size, won't be all the way down to as if you didn't have any implant or fat, but it's definitely still less than what an implant provides.
Can you remove the implant and put fat in the same surgery?
You can. It's not as advisable because you lose some of the space that the implant was in, and all you kind of want to take it out, let it all settle down, and then put fat. But you can do it both at the same time, and that's not a problem. And a lot of people will want to just kind of one-stop shopping. Mm-hmm. Yeah, but in that case, sometimes you're coming back later to do a little bit more transfer to the area from other zones.
Have you had any weird requests for fat transfer in male patients?
No, just to the butt. And that's fine. I'll allow that.
Yeah. They're not to pad the other areas.
You're crazy.
Well, I'm just asking.
Look at you fishing.
I'm just
She's
asking.
Like, mm-hmm.
Well, because some people do inject filler to make it more girth or thicker, or make it bigger. So, do people want fat transferred in there?
I'm sure they do.
Is that something Dr. Crane might be doing?
It might be. I don't know. Maybe.
We have a friend who is he does gender reassignments in Austin.
Gender affirmation.
Gender affirmation.
Give it the program.
In Austin, Texas, Dr. Kurt Crane, and he has made the most phalloplasties. We should get him on. Did you ever do this with you?
No, but
so we should get him to come on.
Yeah.
That would be a very interesting one.
Yeah.
He's created the most phalloplasties, which means penises, in women who have transitioned into men. So that would be a very interesting behind the beauty.
You just want to talk about penises.
I just want to talk about penises. That's all right.
All right, everybody. Well, thanks for joining us, and we will see you next week.
Will we? No, next week something going on Wednesday.
No, right? Or do you have?
Yeah, it's Tyler's graduation.
Oh
yeah. So
we're busy again.
Yeah. So our son is graduating 8th grade.
Busy season.
And it will be next week at 5:00. So we won't be doing Behind the Beauty, but we will be here the week after that. So, well, thank you, Tammy. We enjoyed being here as well. And thank you guys all for watching. Till next time.
All right. Bye.
Bye.